So cancer care delivery research is a major component of the NCI Community Oncology Research Program, or NCORE initiative. Here to present our roadmap for CCD research within SWOG over the next few years is Dr. Dawn Hershman. Dawn is leader of SWOG's CCD program and co-associate chair for NCORE.
So thank you for inviting us to present our new program, which is really an extension of our old program. And on behalf of myself, our incredible statisticians, Joe Unger and Bill Barlow, and my partner, Scott Ramsey, in this effort, I'm going to give you an update of where we are. We have a mission statement in our committee, which is to improve the quality and delivery of cancer care, to reduce healthcare disparities through clinical, epidemiologic, and translational research with the ultimate goal of improving cancer outcomes. Our strategic priorities, or the themes that drive our research in our committee, are really to focus on the quality and improving the quality and value of care, improving the value of the clinical trials that we do, reducing overuse and cost of cancer therapies, understanding the financial barriers that inhibit patients from getting the treatments that we know work, reducing healthcare disparities, improving the dissemination of our findings, and improving cancer care coordination. This is a map of the NCORE organizational structure. I bring this to your attention because many people are at the LAPS sites and member institutions that aren't so familiar with the NCORE. We sort of throw these terms around like as if everybody's supposed to understand it. But with the complete restructuring of the NCTN, so was the restructuring of cancer prevention control and the institution of cancer care delivery within it. It's funded by both DCP and DCCPS. Cancer care delivery is within the research bases, of which there are 7. There are community sites, 34, as well as minority underserved sites, for which there are 12, that participate in this research. And it's really a combined effort. It's an evolution, but in SWOG, I think we're really leading the way because we've been doing research in this area for a while. I want to bring your attention to several studies that we've completed or have ongoing. The first is really focusing on quality. We know that in breast cancer, about 50% of patients either discontinue or have substantial disruptions in their hormonal therapy, which we know is very effective. With the increasing amount of oral therapies for cancer, issues related to adherence and compliance are becoming increasingly important. This was a randomized trial looking at text messaging versus usual care in an attempt to understand how to improve adherence. This study is complete and hopefully will be analyzed soon. This is a second study looking at quality of care, really trying to understand the prevalence and cost effectiveness of HIV, HBV, and HCV testing in cancer patients. This is a study that we completed an early vanguard stage and is just about to be open and activated for all sites. This is actually a CTEP study. It's a legacy study, and it will help us understand who we should be testing, who we don't need to test to improve outcomes. This is a study that is the first NCORE CCD study that was approved, looking at financial toxicity. The PI of this, Veena Shankaran, got a Coltman Fellowship. We're very proud of that. The primary objective is to understand self-reported treatment-related financial hardship in patients with newly diagnosed metastatic colorectal cancer. As I said, this was recently activated or will be activated soon. And it will look at patients over the first year of their therapy as well as their caregivers to understand how we can improve this and how we can develop interventions. This is a study that many of the committees have heard about, especially the breast, lung committees and GI committee, looking at how we can restructure our approach to the development of clinical trials within SWOG, looking at value of information to quantitate the societal value that will be obtained if the proposed clinical trial is successful. This is a study that has had active engagement of the committees, of the executive committee, and of the cancer survivors to help us really figure out how to prioritize the research ideas that we have. This is a study by our group. Scott is the PI. It received one of the PCORI Pragmatic trial funding initiatives this year. It's an $8 million effort to help us better understand how to improve colony-stimulating factor use. It's a trial that randomizes by site as opposed to by individual. We know that a substantial number of patients that have high risk for neutropenic fever don't get CSF, and a substantial number of patients that really should not be getting CSF do. It will randomize sites that don't have electronic order entry to having an intervention that allows us to do electronic pharmaceutical-directed CSF protocol for patients that are at high risk versus usual care, and then a subsequent cohort study for sites that already have this in place so that we can understand the factors that predict neutropenic fever, admissions, and cost. And then there's a secondary randomization in patients at intermediate risk of developing neutropenic fever. We have several studies in development, two that were presented yesterday focusing on the treatment of HBV, whether we should do it prophylactically or whether we should do it based on LFT changes, and then also looking at post-operative adjuvant therapy in patients with incompletely resected non-small cell lung cancer. We have a number of studies where we're sub-studies on top of randomized trials looking at quality of life and economic analyses, and we hope to be able to do more in this arena. We have several recent findings that have been published. Some have been presented here before, but just to briefly overview them. We looked at patient income level and their likelihood of participating in clinical trials, finding that patients that are in the lowest income categories are significantly less likely to participate. This finding holds true for most subsets, and it's something that we need to think about when we want to think about the generalizability of our studies and how we can increase participation when our studies are not enrolling as we would like. This is a study we looked at in terms of disparities, knowing that African American women are more likely to die of breast cancer, have reduced disease-free survival. And on our clinical trials, we found that African American women were more likely to have treatment delays or discontinue early. We always want to have new findings in our clinical trials, but we also want to make sure that they're disseminated in the community. This is a study looking at dissemination of docetaxel after the publication from 9916 showing its benefits that were published in the New England Journal, showing that certain subsets are less likely to receive this standard of care therapy. It's divergent by age. Older age is a discriminator, race, and income, and leads us to wonder, how we can better get new therapies into these diverse patient populations. We had received a grant from the Hope Foundation several years ago to link our clinical trials data with Medicare. So many people have seen lots of analyses from SERO-Medicare. They suffer from issues related to not knowing the treatment or the indications for the treatment. We can overcome that by this type of linkage, allowing us to look at late effects, looking at the effects of comorbid conditions and subsequent treatments and hospitalizations and resource allocation issues of patients that have been enrolled in clinical trials. Our first analysis was linking to a trial that was published in the New England Journal by Dr. Maha Hussain from the prostate cancer group, showing that continuous therapy versus intermittent therapy for androgen deprivation in metastatic prostate cancer. Intermittent therapy did not achieve its non-inferiority goal. The thought was that they would be equal and it would be associated with less side effects. While they found some decrease in side effects for the first 3 months on therapy, no subsequent evaluations showed a difference in those effects. We were able to analyze long-term consequences, looking at ischemic events, endocrine events, depression in these trial participants, and this will be presented at an oral session in the prostate cancer session at ASCO. So we have many opportunities in our committee, travel awards, that we have new RFAs that we'll be soliciting in the next couple of months. Many people that have participated in our committee have gone on to get career development awards. All of our grants have been all of our studies have been supported by grants. It's a good opportunity for people to get external peer-reviewed funding. So our road ahead is really to translate observational findings into interventions so that we can improve the quality of care that we give and to reduce healthcare disparities. Thank you.